Okay, wonderful. Welcome, everyone. This is Dr. Rice, and I am a geriatric psychiatrist at the Jewish Family Service in Clifton, New Jersey. So our talk today is going to be about mental illness in the elderly. As you all know, we have an aging population, and it's going to increase dramatically in the next 50 years. So you're going to be seeing a lot of elderly patients every year. And the number of those elderly patients are going to increase yearly, as well as their symptoms and disorders. So the question is, what are you going to see? Are you going to see anything different? Well, not really, but you may see different presentations. You're going to see a lot of anxiety, as you're already seeing. You're going to see depressive symptoms, and also you're going to see something new, cognitive problems, people complaining of cognitive difficulties. And of course, sleep disorders, sleep problems is always on top of the list. So, how do we continue? Okay, this is just a slide to show you how the population is going to increase, not only over the age of 65, the projected increase, but you're also going to be seeing people over the age of 85. And people are living longer. And consequently, you're going to see not only psychiatric problems, but medical problems and social problems and neurological problems. So it's going to be intersecting with a lot of different areas. Now, some of the key points. Number one, that what we tend to see in the elderly are psychiatric symptoms, not necessarily psychiatric disorders as defined in the DSM-5. These are psychiatric symptoms, symptoms of sleeping problems, anxiety, cognitive problems. These are the kinds of problems that are going to be presented to you as you see these patients. Now, the interesting thing is most of these problems are not going to be treated in the clinics. They're going to be treated by their primary care physicians. So with the majority of the majority of the geriatric population is really going to be treated by their primary care physicians, by their GPs, by their family physicians, and so on. Now, let's take a look at aging in general. We all know that as we get older, we change. We change not only in our body features, but we also change in our cognitive abilities. Let's take a look at this and see, where do you think you are? I can tell you where I am. Have you changed? Have you changed in appearance? Have you changed in your mental capacity? Do you remember as well as when you were a teenager, or in your 20s or 30s? Are you as sharp as are you as acute as you had been before? Well, none of us have been. We've all gone a little bit downhill, some faster, some slower, but we've all changed. So let's take a look at the changes. Now, we all will recognize that we're not as sharp as we used to be. And we're going to hear lots of complaints from older people. And as we get older, we can understand that these are some normal complaints and some a little bit above. The difficulty that we're presented with is, how do you tell the difference between what is normal cognitive changes and what is abnormal? Patients or people are going to be complaining to you that they're not as sharp as they used to be. These are the normal cognitive changes, and they're a bit annoyed at these changes. One of the biggest problems that we all seem to have is this name retrieval. Oh God, I know this person. I can recognize them, but what's their name? That's the difficulty. Recalling the details of certain events is a little bit more difficult as we get older. Now, when we do psychological testing and we begin to test these cognitive changes, we see that there are certain normal changes that occur with aging in all people. I think the biggest one is that we slow down. We're just a little bit slower. You know, to get up in the morning, to get yourself dressed and get yourself ready for it takes a little bit longer. We process things a bit slower. And of course, recalling events, recalling names, recalling faces, that becomes a bit more of a problem. There's another area, and that area is called executive functioning. It's very much like an executive who's running a department or who's running a business. There's a lot of things that are going on, and they're all going on at the same time. We don't multitask as we used to. We don't have the same speed as we used to. Now, what about the physiological changes that are taking place? There's two big things that are happening. We have an impairment of what we call homeostasis, and homeostasis is really keeping things in balance. For instance, when we jump up out of a chair, or we change positions, going from lying down to getting up, or jumping out of bed, trying to get out of bed, what we find as we get older that sometimes we get a little bit dizzy, that the blood pressure doesn't quite keep up with our position of laying down from one position to another position. Normally, as we were kids, as we were young people, that used to be very easy for us. We could jump out of bed. Now it's a little bit, we do things a little bit slower because the body can't keep up with us. The second thing is that we have a decrease in our reserve. In other words, we used to run around the block 15 times. Well, now we make it maybe 3 times, 4 times, 5 times, and we're out of breath. And why is that? It's because the heart is now not pumping as efficiently as it had before. And our reserve, the capacity for it to increase, is not quite the same. Nothing is the same. We see changes in our vision, our hearing, our heart's ability to provide enough blood to the brain, our kidney function. Hey, are we falling apart? Not really. We're not really falling apart, but we do have to listen to our body and understand that these are changes that are occurring all the time. Another thing that we get to see with aging, the number of chronic illnesses begins to increase. And it's amazing that 85% of people over the age of 65 is a low number, have at least one chronic medical condition. Now, 68% over the age of 65 have 2 or more chronic medical conditions. What are these chronic conditions that we begin to see as we get older? Well, everybody complains about aches and pains. They have a little bit of arthritis. They have some hypertension. They have some heart disease. They have diabetes. They're not hearing as they used to. They have maybe cataracts, and a good percentage will also now have a stroke. But chronic illness is what you're going to see as you evaluate patients. You're going to see multiple changes, cognitive changes, physiological changes, health changes, and social changes. Social changes in the sense that a good majority of elderly women live alone. They've lost their spouses. Loss becomes a part of aging. And what's important is, how do people cope with these changes? And remember, they're not one change, but they're multiple changes. Cognitive, physiological change in their health status, and social changes. Retirement. How do older people cope with retirement? How do they cope with living alone? And the biggest question, of course, is how do they cope with loneliness? Now, what we see here is a overlap in the physiological, cognitive, and social changes that are all occurring. And each change impacts on the other change. Now, cognitive and physiological changes also impacts on how we see ourselves in terms of our own self-esteem. Can we do the same things as we used to do? Can we do them as efficiently? Can we do them as fast? And what impact does this have on how we feel about ourselves? And how confident are we in ourselves? And how we see our body? Imagine if a person has a stroke on one side of their body and is not able to use that side. How do they then see themselves in terms of their body? Now, how we see ourselves also as a parent, as a grandparent, as a provider, and even as a loving, lovable human being. Do we feel as lovable when we have a stroke or when we have some cognitive impairment? What does that do to our image of ourselves, our self-esteem, our confidence in how we see ourselves? What are the mental health problems in older people? Well, 20% of people 55 and older experience some kinds of mental health concerns. Now, what are the concerns and what are the problems that you're going to be dealing with and seeing? Number one is anxiety. And by anxiety, we're talking about worrying. What do older people worry about? Do they worry about their health? Do they worry about their finances? Do they worry about falling? If an elderly person has fallen once, then there's a tremendous amount of anxiety that they will fall again. How about cognitive impairment, which is underdiagnosed and undertreated? And mood disorders, of course, loneliness, loss of a spouse, loss of health, and also not as often we may see people with bipolar disorders. Remember, as we get older, we carry the same baggage that we had as when we were younger. If we had depression as a young person, that depression may become chronic and stay with us throughout our life. Important points. Anxiety, depression, dementia, addiction, and other mental health issues are not a part of normal aging. Anxiety is not a part of normal aging. Depression is not a part of normal aging. Dementia, severe cognitive changes, are not a part of aging. Now, let's look at the prevalence of psychiatric disorders. What's number one? Of course, anxiety, worrying. Dementia is number two. Major depression, chronic depression. Alcohol abuse is also a concern, especially binge drinking in the older population. Now, what's the difference between older and younger people with mental illness? Well, the assessment and evaluation is going to be different. The symptom and the presentation is going to be different. The symptoms tend to overlap. There's medical issues and medication effects to take into consideration. And most important is how you treat older people. You don't treat older people the same way as you do young people. We start very low with medication and we go slowly up, but we do have to treat them to the max. Now, our outcome also could be very different. We'll take one as an example. Now, if we look at depression and we look at the DSM-5, which is a little handbook that tells us the criteria for each of these disorders, we see that we have about 9. Okay, we can see that the person who has a depression is going to feel depressed, is going to feel down in the dumps, is going to feel terrible, doesn't want to get out of bed. And also there's a loss of interest in wanting to do anything. There's a tremendous apathy. Now, there may be weight loss, insomnia, agitation, fatigue, difficulty thinking, concentrating, and also important recurrent thoughts of death or suicidal thoughts. This is the DSM-5, and that's our little cookbook that we like to go to, and we like to look at the various criteria for all of these psychiatric problems. Now, if we look at the criteria for depression, and we try to apply it to the elderly, we see that there may be some problems. Why? Because depressed mood and loss of interest may be a symptom of hypothyroidism. Maybe there's a medical issue. Weight loss may be a medical issue, such as cancer. Remember, cancer is most prominent over the age of 65. In a sense, cancer is a disease of old age. Now, insomnia can be from many different issues. As we said, pain in the elderly is a frequent complaint, is a frequent symptom, and pain can keep you up at night. If you can't get rid of the pain, there's no way that you're going to have a good night's sleep. Now, agitation and restlessness can be from pain, but it can also be from the medications. So as we go through the list, we see that the same criteria that may have applied to younger people doesn't adequately fit the elderly. Why is that? Because there's a tremendous amount of overlap. There's overlap between depression and dementia. Many elderly people who are severely depressed can present as having dementia, and we call that pseudo-dementia. But also, patients on certain drugs, like the benzodiazepines, can present also with depression and dementia. Now, movement disorders can also present as having dementia, depression, and so on. What the important point here is that there's a tremendous overlap, and each condition is a risk factor for the next condition. Depression is a risk factor for dementia, and dementia is a risk factor for depression. If you are depressed, you see, there's a good chance that you're also going to develop dementia. And if you have dementia, there's a great chance that you're going to develop depression. So what we're looking at are not only isolated areas or isolated conditions, but we're seeing how one condition affects another condition. Now look, let's go end this by talking a little bit about caring for the elderly. Now, how do you deal with all these psychiatric symptoms? And these can be overwhelming. Number one, you need a very careful and thorough evaluation, and it's really a thoughtful evaluation. Second, you need family members to corroborate the patient's story. Because remember, if you're seeing a patient that has a memory problem, you certainly want to get the impression from the family to corroborate what the patient is telling you. And you need to assess the patient's emotional, cognitive, functional, and medical status. Functional is very important. What can the patient do? Can the patient do the activities of daily living? And can they also complete the instruments of activity of daily living? You want to know where they are and how much help they need and what the safety issues are involved with each patient. And you need to make a diagnosis based on longitudinal facts, and it has to fit the DSM5 as best you can criteria. You also need to be sensitive to the patient's readiness and ability to comprehend the information that you're going to convey to them. And that's an important issue because people want to know, but you also have to present it in a fashion that they can understand. And that is taking into consideration where they are cognitively so that what you present can be integrated and understood. And also in prescribing any medication, we always have to start low in our dose. We go slow by increasing the dose, and we try to reach a therapeutic dose. Okay, when prescribing, and this is true for all physicians, we always have to take into consideration the patient's ability to absorb what we're giving them, to break it down, and to get rid of it. We don't want the medication to stay in the body. So we have to understand the physiology of the patient. And the 6 principal goals of treatment for every older patient is, number 1, maintain the patient's quality of life as best you can. Number 2 is maximize the patient's functioning in their daily activities. Give them a quality of life. Try to enhance their cognition, their mood and behavior, and foster a safe environment. Safety is a number 1 issue. When you evaluate someone, you go into their home, you've got to think of safety. How safe is this patient where they are at the present moment? You have to promote social engagement as appropriate as possible, getting them involved in maybe daycare programs, in senior citizens programs, but promoting, encouraging them to engage socially as best they can. And of course, provide the very best care possible and treat every patient as if they were a family member. And that's our philosophy at Jewish Family Service, and we hope that that will be your philosophy as you evaluate and treat these patients. Thank you very much. We'll end here. Do you have any questions? Hello?
Thank you. Thank you.
Thank you very much, Dr. Rice. We'll just go around and see if anyone has any questions. I know there are a lot of people on the call. So
okay.
We'll start off, we'll go by region and just see if anyone from Florida has questions. Don't forget to unmute yourself.
Yeah, I don't think it was so much of a question, but just sort of a comment and an observation of the presentation.
Yeah.
I love how you pointed out sort of the connection between the physiological changes that happen during aging and sort of how those affect when a disease is onset or something like that, how it can really sort of charge the effect of the loneliness and other things like that. I think sometimes that those are things that we don't completely think about, and it was just a good thing to point out for me.
Oh, thank you.
Thanks, Matt. Let's jump to New York. Anyone from New York offices? Questions, comments?
No questions, but thank you for a great presentation.
Oh, thank you for listening.
Thanks, Carolina.
I agree. It was absolutely a wonderful presentation. Jane from the Amsterdam, thank you so much. It was really great.
Oh, thank you.
New Jersey or Connecticut, questions, comments?
No, thank you, Dr. Rice. It was an amazing presentation. This is Norwalk. Thank you again for presenting this morning.
Oh, thank you for listening.
Hi, good morning. This is Angela. I always have a question. How would you determine you talked about dementia and pseudo-dementia. And so how,
right.
Kind of on a level, a non-clinical level, how would you determine the difference?
How would you determine the difference? Angela, it's not an easy question to answer. And you have to do a very thorough examination. Many times, patients will be referred by the neurologist, and they will say, please evaluate this patient for pseudo-dementia, and expecting that if we treat their depression, that the dementia will then disappear. Unfortunately, it doesn't happen that way many times. And sometimes it's very difficult to separate the two. For instance, one can have a dementia to begin with and also become depressed. And what becomes more prominent is the depression instead of the dementia. Right. And we can treat the depression, that's true. But what happens is that we're still left with the underlying dementia or I would say serious cognitive impairment that's left. So again, it's a difficult thing. Many times we call on the psychologist to do a more comprehensive neuropsychiatric evaluation to make these determinations. But getting back to the basics of doing an adequate examination, a very thorough evaluation, and getting family members to participate. And if a patient has dementia and has depression, they may not be able to give you an adequate history. Going back to the family, going back to friends, going back to people who know them can tell you many times which came first. Was it the depression or was it this cognitive impairment? Deciphering, separating is a tough issue. And many times we're unable to do it. Many times we're left with both. But remember, each one is a significant risk factor for the other. Depression by itself causes cognitive impairment at any age. If you have a depressed patient and you do a cognitive assessment, you will see some impairment. Now, if you have a dementia patient, you're going to also find some features of depression. Each one is a risk factor for the other. It's a great question, and it's a dilemma. It's difficult for us as clinicians, but that's our job. This is a tough one.
Yeah, I would imagine, and as you're saying, they do go hand in hand and probably see them more often together than not. Thank you for helping to give me some more information on that. I appreciate it.
My pleasure, Angela. Thank you for the question.
Okay, I think that's it. Thank you very much, everyone, for calling in, and a special thank you, of course, to Dr. Rice for presenting this morning. It was very informative, the presentation, and we hope that we can actually have some more calls on this related topic, very essential to what we're doing.
Thank you very much, and have a great day, everyone.
You do the same.
Thank you.
Thank you.
Thank you.
Presentation. Thank you.